What's up, guys, and welcome to the Rebalance podcast, where we dive into topics that matter most when it comes to overcoming struggles, injuries, and finding balance in your life. Everybody's idea of balance is that bit different, so my goal is to give you different perspectives, practical tips, as well as expert insights into what it means to live a balanced life. My name is Robbie Cassidy. I'm a physiotherapist and a health coach, and I've been helping people reignite their love for challenge, overcome their fear, and find more balance in their life through the process of self-development. So, let's get into it. What's up, guys, and welcome back to the podcast. Robbie here. On this episode of the podcast, we're going to look at something that you may not have heard before. I want to go into detail on this one. This is a really interesting idea or concept. It's the idea of using a sham surgery versus a normal conservative or conventional surgery and seeing what the results are in each. And I'm going to go through it as I'll talk about each of it in more detail, but I'm going to need to give you a bit of backing, because if you have never heard of this before, it's going to be something that, for me, it was mind-blowing, to be honest, when I heard it first, or when I came up with it first. So I'm hoping that I'll be able to get it across in a way that will change your perspective. I really want this podcast to be a perspective changing for a lot of people, because of how much of an effect it can have on your life and the decisions that you make in your life when it comes to the medical side of things in future, okay, in a lot of ways. And I want to give you a different perspective. This is not to undermine by any means any profession at all. And I'm going to say that a couple of times throughout the podcast, because all I want to do is I want to give you a different perspective on something that is probably more common and more accepted than you would expect. Okay, and it's the idea of using a sham surgery over a conventional surgery and what the research says on it. Okay, so really quick kind of overview of orthopedic surgeries. This is orthopedic surgeries now. We're not looking at heart surgeries or anything here now. we're looking more at like rotator cuff surgeries, meniscus surgeries in your knee, labral surgeries in your shoulder, surgeries that they do in your back. Now we're looking at those more so, and we're looking at ones. Are they necessary? Are they effective? And what is the effect that they have? Okay, so first off, to jump into it, I want to introduce the concept of how this came about. Well, first off, we're looking at the difference, as I said, between sham and conventional. A sham or conventional surgery is when they go in, let's use the knee for an example, and they cut out the meniscus, and then they say, okay, that has fixed the issue or the injury because the meniscus was torn, or they stitched it down. A sham surgery is when they go in, they make a little cut on your knee to make it look like it. They follow through with what the procedure should look like and feel like, because a lot of these procedures, you'll be conscious with them. So they follow through with it, and then they'll send you up, but they actually haven't mechanically changed anything. They've literally just put an incision so it looks like they've made a difference. Okay, and what a lot of research has shown is for many of the surgeries, there's no difference in the results that the person has in terms of pain and disability afterwards, which is crazy to think about. Okay, so to jump into it, we're going to look at, first off, the idea of the orthopedic practices. A lot of orthopedic practices and surgeries are focused in this biomedical idea, okay, and its focus is on the identification, the correction of anatomical or biomechanical abnormalities or issues. And what that means is that if you have a meniscus tear in your knee, you go through an MRI, they say, okay, you have a meniscus tear, that means that you definitely need to get it stitched down, or you need to get it replaced, cut it out. Okay, because the meniscus tear is in the way, that's causing your pain. Okay, but the limitations here is that there's limited success in the pain and disability side of things after. Okay, and there's a big, massive discrepancy in the pathology side of things. What that means is that if you look at people who are asymptomatic, which is have no symptoms at all, and you look at people who are symptomatic, okay, and you put them into an MRI and you look at the results that come back, some of the results you're going to get are crazy. Like 40% of a population of people have bulging discs on an MRI, but they're asymptomatic. They don't have any symptoms of a bulging disc, of what a bulging disc should be. So, like, what does that mean? That means that often the bulging disc is unrelated to the pain that you're feeling. Okay, and pain is it's multidimensional. The other thing is that when you look at disc degeneration, it's like 25 to 50% of people have disc degeneration on an MRI, and oftentimes they're told, okay, you need to get surgery for this, or they have these beliefs that are attached to it. 40% of asymptomatic individuals have an rotator cuff on MRI, And 50% of people with knee arthritis have pain, and 50% don't have pain, if you look at it on an MRI specifically. So what does that mean? It means that our understanding of pain is evolving. We're getting a better idea of it, and there's a paradigm shift between what we see on an MRI and what the changes are in a tissue versus what actually is going on and the issues that we're dealing with. Okay, so I'm going to introduce you to this idea of the neuromatrix model, or the biopsychosocial model, where it talks about how your brain and your consciousness and your perception make up the pain that you feel, and they dictate the amount of pain that you feel. This is what I'm saying, that this podcast is going to be a belief breaker for a lot of people, and some people will fight against this. I know they will, because we get this identity with pain, and as a result, it kind of dictates what we think and how we feel and what we believe in our attitudes around everything otherwise. So I understand if this is the first time you're hearing this, or maybe you've gotten one of these surgeries before and it's helped you, which is great, or maybe you've gotten one that didn't help you, which is hopefully I'll help you understand why that is. Okay, because a lot of times surgery in itself is a last gasp. It's a thing that you're like, okay, all right, I've tried everything else in a lot of ways. I feel like you feel you've tried everything else. This is kind of a means to an end. I just get the surgery done and it'll be done. Okay, when you look at these orthopedic surgeries. But as I said, like in a lot of cases, the surgery has just been made up in a way because it is a last gasp, and it's just, let's go and cut it out and then hopefully it'll fix it. The interesting thing is, a lot of surgeries, if you did the surgery and you didn't do the rehab after, your results would be different. So a lot of time they point the results to the fact that you had to do the rehab after, and your perception has changed of the pain, as opposed to if you didn't do the rehab properly because you didn't get surgery, you didn't feel that it was as necessary to do the rehab. Okay, so which is another kind of a funny way of looking at it as well, because you've been a lot more proactive in the rehab after, because you've been told to do it, and you've been told you have to do it, and you feel you have to do it. So there's a lot more involved in it. As I said, so to jump back into it, the central themes around our understanding of pain now is that the role of the brain and our consciousness in pain perception is huge. Understanding of pain as a measure of potential threat rather than the actual tissue health is really, really important. It's our body's idea of this, like how much threat is there at the moment. I always use the analogy of the Lego analogy. People who listen to this podcast have heard this multiple times. If you step on a piece of Lego at nighttime, the pain that you get is a 10 out of 10, where you can't see it, and so your body perceives it as a really high threat. It could be a piece of glass, it could be something really sharp, so it gives you 10 out of 10 pain to get off it as quick as possible. But if you throw a piece of Lego on the ground right there and you step on it, it's like a 2 out of 10 pain? Like a 1 or 2 out of 10 pain. It's discomfort more so than pain. It's just an annoyance. And the reason is that you can see it, you have accurately kind of assessed the threat, so it's not as much of an issue. And then as a result, you start to dictate your body dictates the amount of pain you should get after that. Okay, so this just shows that it's huge. Our perception of it is massive, and understanding this is huge as well, because it's more about the potential threat rather than the actual tissue health, because the piece of Lego is the same in both situations. It's just in one you perceive it as higher because you don't see it. In the other, you see it, so you're able to perceive it as less of a threat. And then there's other things that could build on that as well. The influence of patient beliefs, the influence of our cognitions on the pain experience. If you had before stepped on a rusty nail and you got what's it called, tetanus, after that, can you imagine the pain that you'd feel if you stepped on a piece of Lego at night after that, because your belief and your body's previous experience, what it felt and what happened to you, that's going to put the pain through the roof, because now it has to perceive it as way higher, because you've had this threat in the past and that threat was actualized, where you got an infection after it. So you can think about stepping on a piece of Lego at nighttime after that is going to be even higher again, if it's possible, for the amount of pain that you feel and your reaction to that. Okay, and that comes down to the beliefs and the cognitions associated with your previous experiences and everything around it. Now, I want you to hold that analogy. I want you to hold that analogy of the Lego and the threat of pain as a result, because that will help you to understand the podcast as we go through it. Now, to jump back, orthopedic surgery now in the modern era, I guess, is more around the biomedical model, where it's to go in. There's more of an emphasis on anatomical and biomechanical correction for pain relief, where if all the other things haven't worked for you, let's go in, cut it out, or try to fix it up, patch it up, and see if that works. Okay, and as I said, like, this is not to undermine any of that. This is to give you an understanding of why it works in certain situations and why it doesn't work in other situations. And the thing is that in a lot of cases, this is really effective for people. Now, there's multiple reasons for that. It's because you really trust your consultant a lot of the time that they're doing the right thing. And they are, in a lot of cases, they're trying to give you another option for try to fix the issue that you're dealing with. And a lot of great consultants as well will try push and say, let's just go for the conventional side of things, and if we have to, we can go for the surgery after. Because with surgery, there's always the side of like the issues that can, the complications that can happen in it with infection and like it not working and all that afterwards. So it's oftentimes a surgeon doesn't just tell you, okay, let's go in and get it cut out and see how you get on. Oftentimes the good ones will tell you to go away, try these other aspects and see how they work for you, and then we can go for it. Now, the thing about it is that when you are going in for a surgery, your brain interprets that, and your body and your beliefs and your whole consciousness interprets that as you're going in and it's going to be correcting a faulty tissue. Okay, and the interesting thing with that is, as a result, when you come out, you're going to have decreased pain just in general, because especially if you've really had a good relationship with your consultant or with your surgeon, it shows it even higher. Like, one of the highest predictors of success in any injury at all is your relationship with the therapist. And that's not just me throwing it out there, that's what the research shows. So in this case, you're going in, you feel, okay, this is the faulty tissue, you've seen it on the MRI, they go in, they cut it out, now you have decreased pain and improved function afterwards because your brain has interpreted it as that issue been gone and has disappeared. Okay, and this comes back to, obviously I'm looking at the neurological side of things there. At the other side of it, it's more like with the surgery, oftentimes people say, well, that's the reason that it's fixed is because that piece of meniscus isn't catching anymore, or it's because I repair the rotator cuff, that's the reason that it's fixed. But it's more to do with this brain's interpretation of why it is fixed. Okay, and simple one, right? If you break your leg in a car crash or something, or like, let's say how McGregor broke his leg, where it was a kick and it's basically snapped in two. In that case, now I'm not going to go in and say, yeah, go in and do a sham surgery there and see how you feel. It's a pretty significant fracture. They go in, fix it up, they do God's work, and you get sent out and you do all your rehab after, and it improves. Like, that's a really, like, and obviously the pain is going to improve as a result. Like, that's a clear indication that surgical intervention is necessary. I think we all agree with that. I think we all understand that. What we're looking at more so when we're looking at sham surgeries is when you're looking at chronic issues that keep coming up, and then they're pushed into like a surgical procedure because they don't feel that there's any other option. Okay, so in that one of like a severe breaker, in a lot of cases where they do need surgery, it's definitely the best option, but in other cases it may not be the best option, and that's what I want to show you. Now, how they figured this out, this is really interesting. So they looked at sham surgeries. Now, what is a sham surgery? By definition, it's a faked surgical intervention that omits the therapeutically necessary step. So that means, as I said, instead of going in, cutting the meniscus out and putting you on your way and getting to the rehab, they just cut it. They go through the surgery as if it's as normal. They do all the pulling and dragging, and they kind of all the changing with the tools, and they do all the messing around, so it looks like they're doing the whole thing, but they don't actually do anything to the meniscus. They just come back out and they leave you as be. So it started in 1959. A study showed that there was comparable outcomes between a real and a sham procedure. And this is, even if you want to go back before this, I would say that some of the ideas of this had come from World War I or II, I don't know exactly which one it was, where they ran really low on morphine. So what they did is they changed the morphine out with water, and it was saline solution, and they still injected it into the people, and they told them that it was morphine. But the people had similar results with pain relief as a result, because the body felt that it was getting morphine, because that's the body's perception kicking up. Okay, I'm sure that probably played a role in helping them to develop this idea of the sham surgery. But there's not a lot of them published, and for good reason, because it's there's a lot of ethical considerations of telling somebody you're going in for surgery, cutting them, and then sending them on their way, and actually not doing anything. So for the people who may want the surgery, let's say. So the idea was initially that it was the placebo effect. Now, you often hear of the placebo effect, but what is the placebo effect and how can it kick up, or what contributes to it? Well, if we understand that pain is dictated by your nervous system, then the placebo effect is your nervous system deciding not to give you pain in this case. Okay, and that's a huge thing. And the better understanding we can get of that, the better it is to build on top of that. Okay, and as I mentioned before, it's something that it takes a while to get an understanding of, but it's in everyday life. Like if you look at your neck, like what I often get is people with neck pain come to me, and it's neck pain when they're on the computer. But then if you start to look at their lifestyle and their life and their sleep and everything around them, it's not that they're sitting down crouched over a computer all day. That's a very small part to it, because how much of the population does that and how much of it actually has neck pain? Because if that was the case, everyone should have neck pain, because everyone's in the same position. But that's not the case. So there's other factors contributing to that neck pain. What's up, guys? Robbie here. I hope you are enjoying the podcast so far. I want to take a moment just to personally ask you for your help. If you're enjoying the podcast, would you be willing to share it with someone you think would love it too? Maybe a friend, family member on social media, or even if you just brought it up in conversation with someone you know. The recommendation means the world to us, and it's because of people like you that we get to be able to produce this podcast on a weekly basis. So thank you so much for your support so far, and I would love if you could help us reach even more people who could benefit from it too. Really appreciate you, and we're going to jump straight back to the podcast. There's other factors contributing to back pain. This is why I developed that spine initiative course, is to help people understand that there is more to back pain than you feel, and in a lot of cases you've been given different diagnoses for it, but it's not actually been the problem. And if you continue down the path of these diagnoses, that can develop an issue where you feel like you've done everything. You have these certain beliefs around how your back is broken and your body's broken, and as a result then you feel you can't do anything, so you don't exercise, and it just continues to get worse, and then you go for surgery and all these other aspects to that. But I digress, and I go back to the podcast on that. In this case, you have to look at why, or would a sham surgery work, or what would it work for? So when you look at the research and how much they did, it's hard. There's not that many of them. Okay, so most of the sham surgeries that they've done, or the research on the sham surgeries, has been to help and assess the efficacy of them. And there's actually a good systematic review by Louw, L-O-U-W, 2017, and they looked at the effectiveness, or they looked at sham surgery in orthopedics, a systematic review of the literature. Okay, now to draw from the results of that, what they looked at there wasn't that many ones that they could pull from. There's about six RCTs they were able to look at, and it was covering 4 different surgeries. Now there's other ones as well that just didn't apply to it, but the majority of it is around lateral epicondylitis, which is actually tennis elbow for people who don't know, rotator cuff repair, vertebroplasty, and meniscal repairs in the knee. Okay, and the outcomes were strikingly similar to the real surgeries in terms of pain and disability. So there was 277 patients. Sham procedures resulted in outcomes on par with the real surgical interventions. Okay, when it looked at it overall, it found that the ones that it was able to find that actually fitted their methodology, that there was as I said, it's similar to real surgery in terms of pain and disability when you measure it that way. And as I said, with surgery, that's kind of the reason that you go for surgery, is it not? In a lot of cases, obviously there's other surgeries that you can get, but in orthopedic surgeries, many times it's that you have disability due to pain, and that's what you're looking to improve. And it was looking at 3, 6 and 12 month markers, and even 2-year long markers. So it was following up, and it was checking what the patients were like after that stage, these individual RCTs were. And in most cases, and in significantly statistical cases, they were similar results, if not the same, when they looked at a 3, 6 and 12 month follow-up in terms of pain and disability. So that basically says that the surgery itself shouldn't have had that much of an effect on them, because if the sham surgery and the real surgery have the exact same results, then what was there need for the surgery in the first place? And this is another one as well. It comes back to a lot of medications. It's I won't go down this path because this is not my realm, but I know there's other research on statins And from my knowledge, I think statins are for cholesterol. But anyway, I remember seeing somewhere, and don't quote me on this, but I'm going to say it in the podcast anyway, so people are going to quote me on it either way. But it's going to be there. It was like statins work for 40% of people, but it works in 37% of the placebo, where they don't actually take the statin. So does the medication work or not? That's up to you. That's an interesting one. Look into it more. Don't take my word for it, but it's an interesting one. It just shows the effect of the placebo effect in a lot of cases. And when we go back to Sham Surgeries, you can see that this is obviously the same here with a lot of these surgeries. So when you going back to the surgeries and the systematic review where it finds that they were on par with the real surgical interventions, what does that really mean for us? And what can we pull from that? Is it that we just go in and start doing all surgeries and just do sham surgeries? No, I think that's a bit of a crazy solution. And it'd be outrageously expensive just to go in and get people to just cut your skin. I could do that if you wanted me to do it for you. I'm just not covered for it. So anyway, to get into it, so what we need to do is we need to challenge what the established norms are. Okay, we need to look at what we classify as what needs a surgical intervention, and we need to kind of reassess that. I think that's going to be really important. And then we need to look at the biomedical model and the biomechanical model and really question what's the best option for people, because with the surgeries, with that, you obviously have the complications that are associated, and if we can avoid those complications and get the same result, all the better. Okay, and that's a huge one, and if that's the goal of it, okay, and that's what I'm always trying to push, is that we need to take responsibility, and we need to look at how we can work on it ourselves and see if that improves it. And as much as we can do that, the better, because then first off, apart from you fixing the issue, you now have the confidence in yourself to improve yourself. So there's a lot more to it. It's not just the mindset of fixing the issue or injury, it's the mindset of improving everything else around it. The sham surgeries, what they've actually done is they've challenged the foundation of what we feel works. So do we actually need to go in and change the meniscus or cut it out? Do we need to do a rotator cuff repair? Because the rotator cuff repair was a very similar one as well. Within a year follow-up was nearly the same results. Do we need to do these surgeries, or can we do something else? There was actually a really interesting one where they went in for a discectomy. They cut out the disc, like they did a real surgery. And then they found that the people that they showed the disc to, where they gave them the disc that was cut out, the little piece of it, versus the people who didn't get the disc after, had a better recovery, had better results in a year follow-up. Because there again, that changes your perception about how good the surgery was, and it shows you there's physical evidence there that okay, that it must be better, because look, I have the disc, so that can't be the problem anymore. And this is why it's so interesting. This is why I'm so interested in pain, is that there's so much more to it than what meets the eye, and the better understanding we can get it at, the better we can look to improve these injuries and issues. And that's why this old model is it's a small bit outdated. So if we know there's a similar relief, the potential influence then of the visual, the auditory, let's say your different sensory stuff, it's shaping our perception. As I said, when they gave somebody it had a better improvement. We need to start to think about how we can manage pain and how we can improve people's pain in other ways. Okay, I'm focused on what they found in the research in a lot of cases is that if you focus on explaining pain through the neurobiology and the neurophysiology, and anyone who wants to know about that, listen to the podcast that I've done. Listen to how to fix a chronic issue, what the real cause of chronic back pain is another one that I've done. Most of my podcasts I talk about this. Listen to those to get a better understanding of what's contributing to your pain. And then if you can get a better understanding of it, that actually changes the pain that you feel, because you have a different perception on the pain. Okay? That's a free way of improving your pain. Just listen to the podcast. Cheeky plug, but that's the way it is. If it improves your pain, what about it? So what we need to look at then is the transformative side. So how we can redefine what pain is and the perception, as well as improving movement, reducing the fear, and reducing that alertness of your nervous system. And I often talk about the burn spot on your nervous system, how to calm that burn spot down so it's not affecting you that much. And in a lot of cases, as I said, where you're looking at patients are reporting enhanced pain perception and movement post they having a conversation with a physio or a doctor without any physical intervention. So they go in, they have a chat with them, and I often get this, and I'm sure you've had this, some people call it, I'm pretty sure it's called white coat syndrome, where you go in, you chat to them white coat syndrome actually, sorry, is when you go in, your blood pressure increases just because you're in a hospital setting. But where you go in and you talk to a physio, and then when you come out, it's like a breath of fresh air, where you just feel that, geez, I feel a lot better now about that, and I don't have as much pain anymore because I kind of got it off my chest and I have a better understanding of what's actually going on. So that's real change in pain with no change in the physical at all. Okay, and it's backed up by the literature. There's a lot of research on it showing that if we can get a better understanding of pain, if we can get a better understanding of this neuromatrix concept, then we can look to improve our pain without actually having to do too much else outside it. And then when you look to add on top of that confidence building activities, you can and actually fix the, let's say, physical issues that may be there. Like if you have a torn hamstring, that's understandable, you need to fix that as well. But or an easy example that I use is the ankle. If you have a sprained ankle, okay, you have damaged your, let's just use the ATFL, but the whole ankle has blown up and it's gotten really sore. But that's just because that's the pain response of the body making it way more painful. But there's only a little ligament that's injured. So if we can start to work on that, you'll find that the whole pain response will calm down and we can improve and fix the physical. So this does apply to both chronic and acute injuries. Chronic injury is obviously a long-term injury. An acute one is one that, like, you got to sprain the ankle and it gets sore. Important. I want you to understand that. I want you to understand that these sham surgeries, the reason that they are so important to, I guess, kind of get your head around, is because that it shows that you don't need to actually change the physical in a lot of cases. It means that you can still make huge improvements in your pain, your function, and what you can do by getting an understanding of your pain and working on that. A lot of these interventions that try to fix the biomechanical or mechanical in ways don't actually fix the issue, because the issue is deeper than that. The issue is more of a subconscious issue. It's more of a neurological issue. It's your perception of the pain that can contribute to the pain. And if you think that your back pain is the worst back pain that you've ever had, or the worst thing, or if somebody has told you your back pain is because of your posture or it's because of your discs, and you've gone in and you've looked at an MRI and you can see you have 4 bulging discs and that's the result of the back pain, it's most likely that could be contributing to it slightly, but it's most likely your perception of that's contributing to the pain being a 8 out of 10, 9 out of 10 pain, when really the pain should be like well, there's no should or shouldn't about it. You could have 0 pain and still have those bulging discs. Like, that's because we've seen that in the research that there is a lot of people, especially as you're over 30 years old, you're 30% likely to have a bulging disc and no pain. That's just the results of it. So that means that if we start to work on the strength, we start to work on the confidence, we get an understanding of our body and understanding of our pain, we take care of all the things outside of it and really focus on a holistic approach to our pain, then we can improve it without having to go under the knife and risk all these other complications. The other side of it is, if you go under a knife and you haven't taken care of all these other factors that are contributing to your pain, and then you come out and you still have the same pain, how does that make you feel? Like, that's really disheartening for people. And I've seen people really break down over that, where they feel that they have lost complete control of their body because they feel that they have tried everything else, but really they just have been led down this biomedical path, this biomechanical path, and it's not serving them and it's not fixing them, and then as a result then they're still dealing with the same issue for years to come, and it just gets worse. And you don't want to be like that. I don't think you want to be like that anyway. So I want you to think about that. If you need to go back and listen to that podcast, because I was banging through those things very fast. In its essence, it's about, they looked at sham surgeries and they looked at real surgeries. They did the same ones where they brought someone in for, let's say, a knee surgery or rotator cuff surgery, or there was a vertebral surgery as well. And they performed the same surgery, but one of them, they just went in, put a little cut on it. They never removed anything. They just basically went through it and acted it out, like they were literally acting it out. And then the other one, they did go in and do it, and they did change the physical side of things. But when you look at it 3 months after, 6 months after, and 12 months after, that the results were the same. The person still had the same level of pain and disability, or still had no pain or disability as a result of that. So it goes to show that your pain is dictated by your brain and nervous system in all cases. And there's other things that can contribute to that being higher or lower. But if we can get an understanding of that, if we can change our perception and we're not fearing pain and we're not scared of it all the time, then we can see long-term improvements, and then we can fix these issues. I will go into more detail in other podcasts. I'll definitely go into like the more specifics on like the rotator cuff ones and the meniscus ones. I just wanted to give you here an idea of sham surgeries and versus real surgeries, and in certain cases how they did work. Now, that is not to undermine the surgeries or the surgeons by any means at all. I wanted to do that just to give people an understanding of what actually contributes to pain. And like they are trying to, in every case, I hope that the consultants and the doctors and the physios and all that are doing their best to help you out, and they're not doing it just to get money in any way. It's that, because that's what people argue, they're doing all these just things to get money. It's not, I don't think. Well, maybe some of them are, but in a lot of cases it's not. They're trying to help you, and that this is your option. I always use the analogy of, if you go to a Ford dealer looking for a Volkswagen, you're going to get a Ford. Okay, so if you go to a surgeon looking for a conservative treatment, you're getting the Ford, you're getting the surgery. That's just the way it is in a lot of cases, because that's not their profession. If you come to me looking for surgery, you're getting conventional treatment. You're getting the physical, the holistic treatment. I can't go in and do surgery on you because it's not my path. So you have to understand that. If you go to a nutritionist looking for rehab ideas, you're probably not getting that. You're probably getting rehab ideas in terms of protein. Okay, so understand that you can't go to a Ford dealer looking for a Volkswagen, and it's important to get an understanding of everything else that's going on outside it. If you do, you can improve your pain. But that is all I'm going to talk about. So definitely, if this is your first time listening to the podcast, make sure to hit the follow button as I go into a lot more detail on this. If you want to learn more about what the deeper levels of pain are, check out the root cause of all chronic back pain. It's a podcast that I've done before, and how to fix a chronic pain, or how to fix a chronic issue. That should put you on the path of fixing these. If you're someone who's dealing with back pain at the moment and you want a clear program or a clear method of how to improve it and get back to exercise, check out the Spine Initiative program. It goes into a lot of detail on the issues, what's contributing. It talks about this neural matrix model. It goes into a lot more detail on how you can fix it, all the other factors that could be contributing that are not just the physical, all like the sleep, the hydration, everything else around you, your beliefs, your attitudes, and how to break those. And it helps you to build back confidence and get back to running a 5k. You can run that 5k on the road, or you can run it in the gym. It doesn't make a difference on a treadmill, but the results from the people who have done it so far have said that the confidence it has given them is unbelievable, and they have now since gone on to do way more things after, in terms of getting back to exercise and starting to get back into like little competitions or little activities like park runs and stuff like that, where they can do it with friends and they don't have to be afraid or fear their back anymore. So check that out. But that is all from me. I hope you got a better understanding of it, and hopefully now you are more informed when it comes to surgeries, when it comes to sham surgeries, and when it comes to pain. Chat to you all again next week. Have a good one. Okay guys, thank you so much for listening to today's podcast. I hope you enjoyed the show. If you're looking to learn more about what we do, as well as check out any of the mobility and rehab programs we have available, just head over to the description of this podcast and you will find a link to all the programs there. As always, thank you for listening, and I will chat to you all again in the next episode. Have a good one.